The Stanford group in the United States that was really kind of led by Dr. Guilleminault from France, who was there and passed away a year plus ago. He really led this, for us. And for those of us in this field, it kind of gave more credibility for me to talk to my, colleagues in medicine, saying there are issues that we're seeing that are going undiagnosed. The American Dental Association is kind of paying attention to this now, and you have people like Steve Carstensen, Kevin Boyd, driving this home and saying, most of these kids, you really kind of have to think that they have some potential form of maybe a severe obstruction until proven otherwise. And a lot of these kids follow patterns. So when I see these kids coming in, we see so many of these kids coming in with a breastfeeding difficulty, bottle feeding difficulty, untreated. Over the 20 plus years of doing this, I've seen the kids coming in at different points in their growth and development. And it's not that each one of them is definitely going to have a problem if they don't treat it, but they're more likely to. And they're more likely to have these patterns that we see. We see the breast or bottle feeding difficulties. The next age group is when they transition onto solid foods. A lot of them start to struggle. They get labeled as a picky eater by somebody. They see you. They see the feeding therapist. They see the speech therapist. And then they pick it up. It's like, I think there's something going on. Well, how come nobody else told me about this? How come my pediatrician's in denial about it? How come the ENT I went to said nothing? My dentist said nothing, that they're fine. They're growing, they're gaining weight, they're fine. So when we look at those pieces of the puzzle, I say, yeah, that's one little piece there, but it doesn't mean that there's not this other piece going on here. So the studies that have been shown out here, I'm not going to go into the details, but they're here. So a frequent phenotype for pediatric sleep apnea was a short lingual frenum. And I'll kind of give you a couple schematics on why we think that's the case and how these things are affecting orofacial growth and development. But there's studies, they're being published, and it's not the clinical studies that maybe the American Academy of Pediatrics or the American Association of Oral Maxillofacial Surgeons or ENT groups want us to provide them. We can't give them those double-blinded, clinical randomized controlled studies. But at what point, do we talk about experience translating into evidence, in medicine and practice? And that's a balance that we all struggle with at this point. Because what we see in clinical practice on a daily basis, we're up against these ivory towers, and you go back to that slide looking at the castle, and we're all trying to, break through there, because we're seeing things in the trenches that are not being, thrown out there for education. And that's going to change, with the help of this foundation as well. When we look at tongue posture, that's one of the biggest things that we're looking at right now as one of the pieces of the puzzle for airway growth and development. And you talk about this craniomaxillofacial respiratory complex, as we term it, and soft tissues impact that. So tongue posture, when you're talking to the oral myofunctional therapist, talking to the speech therapist, and talking to the feeding therapist, lactation consultants, we want that tongue resting, that normal resting posture of the tongue to really fully be on the palate. And what we have been finding, and the research shows, there's not a lot of pressure that's needed to help mold these palates as these kids are growing and developing. And we see so many of these kids that have restricted frenulums, their tongues being held down and back. And what starts to happen, as that's being held down and back, not as only is it closing off the potential oral pharyngeal airway space, but when that pressure of the tongue is not being exerted on the palate or the roof of the mouth, we tend to start to see these palates start to become more narrow. They arch up higher. Some people say there's a bubble palate, there's a high arch palate, what's going on here? And I've had some people say it's because of the tongue tie. It's like, well, that makes no sense. And what we have found is when we release tongues and talk about getting that tongue posture resting on the roof of the mouth, not just by doing the tongue release itself, but doing functional work in addition to surgical release. And we try to do that before and after releases. We talk about it with lactation support. We talk about it with speech and feeding. We try to do prep work as far as neuromuscular education and re-education, strengthening these muscles beforehand to try to get that tongue up and resting on the roof of the mouth. And the studies that Guilleminault published and Dr. Zaghi and Yoon out in Stanford, UCLA area, showed that tongue ties are a marker, when we have shown that to be a marker for predisposition or growth and development and potential obstructive sleep apnea. And we see that it affects growth and development of the face and airway. So we see tons of kids coming in, they're going in for palate expansion, they're removing teeth, and the orthodontists have no clue what they're dealing with. And then nobody's screening for a tongue tie. They're doing palate expansion, they're putting the kids through torture. They take all the braces off and they relapse and collapse to where they were because nobody addressed potentially a ties or tethers or soft tissue areas. And there's other pieces of the puzzle. We talk about nasal breathing, we talk about all of these things, but when you look at the growth and development of tongue position and how it's affecting that palatal growth and development, when that tongue is not resting on the roof of the mouth, that palate gets narrowed, it arches up higher, that starts to close off the nasal cavity a little bit. Maybe you start to get some more deviation of the septum. A lot of the kids, they can't breathe through the nose, they're gonna breathe through the mouth. Now they have that tongue, it's not resting on the roof of the mouth. They can breathe more easily through the mouth. And we see this whole cascading progressive event. Dr. Parkles talked about that. They see that all the time. And we work as teams. I don't treat all these things. I don't do the full airway evaluation. I need to have my ENT colleagues look at the adenoids and really look at the nasal cavity, look at all these other areas that I don't treat, and kind of come up with a comprehensive treatment plan. So again, this is just one piece of the puzzle. When we look at the soft tissues, and I'll jokingly say, our tongues and our lips, and when we deal with our oral myofunctional colleagues, we talk about these as nature's braces. So your tongue is resting on the roof of the mouth, helping that palate expand, helping, the lips are helping those teeth come back into place. But if you have a restriction in those areas that's preventing that, it can kind of, set that domino effect and that cascading effect down a course that we don't want to go to. I'm in a unique position to talk to families when they have babies. And when I spend so much time consulting with them and talk about these patterns, like, that makes so much sense. You just described my husband, you just described my father, my older child. How come nobody? It just makes sense. It makes mechanical, structural, physiologic sense. So when you try to keep it simple, it's like, yeah, most of it is probably connected and related, and it's not all of these other complex things that we're dealing with. And there's been, studies looking at, safety and efficacy. When we circle back to the procedure, the surgery or the procedure people talk about, we always circle back to risk versus benefit. And in medicine, surgery, we're always coming back to what's the risk, what's the benefit of treatment versus non-treatment. And the fortunate thing for what I do at this point in surgery, I've gotten away from more risky things and I treat less risky surgical things. And one of the simplest things that we do in surgery is a frenectomy, frenotomy. Frenuloplasties, start to get a little more involved and potentially more risky. But when you look at that risk, it's a very low risk and it potentially can carry benefits for children up through, growth and development. And we see a lot of adults coming in on the flip side looking for treatment. What we're looking for, and I'm not going to get into much of the surgical stuff here, but we're trying to just release these restrictions to get better range of motion and better function. Talking to, compensations and, the body aspect of these things all being connected, I've learned so much more from my colleagues, not in my area of specialty than anyone else. I learned so much from my OT, PT, chiropractic, body workers about this stuff because we see changes. There's been anatomic dissections looking at the connections, the fascial connections. When you talk about it's all connected, yeah, all of these things are connected, and we're also busy, just treating things with how we were taught and not looking outside of the box or, looking at it with a different, prism or glasses. The tongue is connected to the toes, and that's not just a little song that we talk about, the nursery rhyme. But there's actually been anatomic dissections, and this slide shows it. This is called the deep front line of fascia. I don't have to talk about that to my OT and PT colleagues or chiropractors, but there's connections that run from the tongue all the way down to the toes. We see so many of the kids coming in with compensations. We see them coming in with torticollis, neck tension. We see them coming in with toe walking and all of these other body issues that are going on. We see older patients coming in with severe neck strain, TMJ problems, jaw stability problems. Some of the issues that we see with just airway compensations, many people start to develop more of a forward head posture to kind of open the airway up. And when we do these releases, then the tongue starts to move up and forward. They get fascia release. So many of our patients will say, what did you do? I feel so loose. I don't know what you did. And then we explain there's connections, there's fascia connections. And this is not just, hocus pocus stuff. We're trying to understand the changes that we've seen along the way. So working as a team, is a very big thing here, and I work very closely with my bodywork team because it's a piece of the puzzle from the neonates on up through the adults. One of the other compensations we see, which I didn't really talk about before, but when we talk about tongue ties and tongue posture, when these kids really can't have their tongues resting on the roof of the mouth, one of the issues, we think it's either airway protective mechanisms or they're trying to get the tongue up to the roof of the mouth, so they develop tongue thrusts or tongue thrusting habits. And as a secondary result, when they are constantly doing that tongue thrusting habit, it starts to affect their teeth and orthodontic issues. And these kids get their teeth splayed out and they have the typical, open bite, the tongue is protruding through. Some of them are thumb suckers, and maybe they're sucking the thumb to get that input, that neural input. Maybe they're trying to move their tongue forward to open the airway. So we're looking at all of these things.